to happen in this hepatobiliary event. Uh, so, so my main concern, I am Dr. Arun, consultant gastroenterologist, main Apollo Greens Road. Today, Charan Pharma suggested me to talk about one important area right now about obeticholic acid. That's one common molecule being tried nowadays by most of the senior consultant gastroenterologists. So if you want me to talk about that area, you should remember the basic scenarios if you want to look into that. The most common event what we are facing right now about is primary biliary cholangitis, and apart from that is non-alcoholic fatty liver disease. This non-alcoholic fatty liver disease is being more common nowadays in India, even more worsening than the scenarios tend to be more severe. As we all know, initially the liver disease has been taken over by alcoholic pathology. Now, even more westernized scenario is happening in India. Now, the non-alcoholic fatty liver disease is being more commonly occupied by most of the patients. Because of that, the patient is going to land up with major dreadful complications like liver cirrhosis, and major complications like hepatocellular carcinoma, and sometimes the patient may deserve liver transplant, and the patient may sometimes succumb to this kind of illness. So tracing the fatty liver is most important scenario. Once the patient becomes followed by the patient can go for worsening of events in the form of non-alcoholic the patient still was and later by cirrhosis and later by hepatocellular cancer or death may supervene in this kind of pathology. That is one entity what we are going to take over right now. And apart from that, the other not very common scenario what we are facing, but in most of the high volume centers of hepatology, we'll be coming across with this kind of scenario. That too in female population is more commonly occupied, is nothing but PBC. What is this PBC? Cirrhosis, that now the terminology has been taken over by primary biliary cholangitis. Why means this condition is most of the time a autoimmune pathology. If you are going to discuss about the liver scenario, it's very simple to take on with alcohol or non-alcohol based conditions. It could be because of metabolic conditions, or it could be because of any condition which is going to damage your intrahepatic biliary radicals and your biliary ducts. This primary biliary cholangitis, what is going to happen? It is going to damage your median multiple trigger mechanism, either injury or by idiopathic focus that could be predisposing to T cell mediated inflammation. Once the process is going to get activated, there might be evidence of ductopenia, there might be evidence of fibrotic changes may happen in this kind of pathophysiological focus. So why I'm going to focus, because these two major indications in the field of gastroenterology where the newer molecule like obeticholic acid being tried. So to discuss about this obeticholic acid, I'll be checking on my discussion right now the brief introduction about this primary biliary cholangitis. If you're going to look into that, it's nothing but a cholestatic pathology. What do you mean by cholestasis? If there is any evidence of obstruction to your bile flow, it could be because of mechanical obstruction, or it could be because of non-mechanical focus like your metabolic and genetic or viral. So many events are there to produce cholestasis where your bile flow, if it is going to get impeded from the part of duodenum to your ampulla, all those areas, if it is going to get blocked, that shows evidence that the patient is going for cholangitis and primary biliary cirrhosis. This condition, it's most of the time a autoimmune liver disease. If you're going to look about this autoimmune focus, there are various criteria that to diagnose this autoimmune liver disease, but this autoimmune liver disease is predominantly, it's going to get destructive. There is high possibility for you to get worse. And once the patient is going to land up with this kind of primary biliary cholangitis, see, you can stop me at any point of time. This is very simple forum, small area to discuss, but it's not purely academical. I would like to take you more theoretical, clinical concepts. How are you going to approach this scenario? Any patient of middle-aged women who are going to land up with this kind of background, in the background of ascites or other thing, in the background of decompensation or other thing, or sometimes even in the background of compensated cirrhosis, always you need to keep all those pointers in your mind, not only to think about these common presentations like viral infections, other thing, you need to keep this rare autoimmune possibility like this primary biliary cholangitis can supervene. So any patients who are coming with elevated liver function in the background of jaundice and other things, you need to work up the patient for evidence of cholestasis. What are the clinical presentation for cholestasis? As we all well know, the commonest will be the jaundice. Next to that, you can able to look at the jaundice in your eyes. You can able to look at the jaundice in your oral cavity, in your palm, soles, extensively in your throughout your body. You can able to look at the severity of your jaundice, followed by you need to assess whether the patient is having significant evidence of cholestasis, like your pale stools, or in the background of significant pruritus, or in the background of high colored urine. These are all the pointers can be taken, and along with your bile salts, pigments tends to be positive sometimes, and your clinical background tends to be worsening in the form of histological changes as the day progresses. See, once a patient is going to land up, if it tends to be a female patient who doesn't have any major inherited risk factors, who doesn't have any major then not much to be alcoholic or not much to any focus, but this kind of patients, if it is going to land up with this kind of scenario, you need to be very cautious. You need to look that we are going to miss out something or not. See, this condition, what is going to happen, it may predispose to persistent progressive injury to your biliary tract, which may predispose to fibrotic changes. So once the progressive injury, if it is going to take on this normal bile duct, it's going to get inflamed, distracted by multiple segmented layer of involvement, followed by the bile drainage. If it is going to get blocked from your gallbladder to your hepatic, from your hepatic to common bile duct to your ampulla of Vater. So if it is going to get blocked in that area, there is high possibility for you to land up with cholestatic pathology. And this may predispose to scarring, your fibrotic changes, your cirrhosis, and finally, you may land up with a liver failure or a acute on chronic liver failure or a fulminant hepatic failure can supervene in this kind of scenario. So epidemiology, if you want to look into this primary biliary cholangitis is predominantly in female population. The worldwide prevalence almost going up to around 940 cases per million. So middle-aged women around 30 to 40 years of age population are maybe more common preponderant to this kind of events. Always any women population, if you're going to see with eye jaundice with the background of cholestasis, don't forget to remember, don't forget this common scenario like primary biliary cholangitis. It could be because of, see, Wilson's will always very uncommonly report with cholestatic pictures. So Wilson's don't think that's the first possibility in the background of female. Autoimmune liver disease and primary biliary cholangitis will always go with a overlapping events. Both of them will mimic based upon your markers and other things you can able to diagnose. If you want to diagnose autoimmune liver disease, you need to look for a huge list of markers are there. If you want to diagnose this primary biliary cholangitis along with other criteria, there are a list of markers is there if you want to diagnose that. And the most common age of presentation is what I've been discussed with you, or the third to fourth decade of life, and sometimes even in sixth to seventh, I mean, up to fifth to sixth decade also, there are high possibility. Some patients, in our experience, we have seen some patients with this kind of presentation also. And race-wise, it's more in favor of Northern Europeans and less common in the background of any African descent population. So etiology, most of the time, any autoimmune liver pathology, the etiological trigger will be unknown. That's the most common thing I would like to say. But there are a huge number of postulates, so much of hypothetical events being there to think about that. One is because of genetic events. There are high inherited factors, more than 500 to 1,000-fold increased risk of this kind of patients to go for PBC. And now, the gut dysbiosis is one problem which is going to take on the discussion about alcoholic hepatitis, so many other GI conditions, because the gut problem, the gut microbiome is being considered as a separate brain right now in your GI tract. So any infection, if it is going to have, if the patient is going to land up with any organisms, any septic focus in the background of any enterobiasia, if it is going to get focus in that, there is high possibility for this kind of patients can land up with this kind of PBC. And usually some gram-negative infections like UTI can have high possibility for this kind of patients to land up with increased worsening. And there's so many examples of that to prove it that, but most of the time will be inherited, idiopathic focus, will not be having identifying any triggers. Only thing we need to look for the pointers and markers. The pathophysiology, the cholangiocytes, we should remember about the liver. One is hepatocyte, another one is cholangiocyte, which is nothing but the bile duct tract injury. The cholangiocyte, once it's going to get injury, how does it going to happen? Either by immune mediated mechanics or by your bile acid mediated injury. So the bile acid is one important pathway, but it's supposed to remember that Once a bile acid is going to get involved, the patient can land up with your worsening of cholestasis, ductopenia, fibrosis, your cirrhosis, and followed by the patient can land up with dangerous liver failure, which may deserve intensive care management and which may deserve the patient for liver transplant and other workup and other scenarios to be taken on. So how the disease event is going to get progress. See, the patient can progress to end-stage liver disease. Usually, it may take a period of around 10 to 15 years if you're not going to say, and if you're going to left untreated, the patient can have worsening of events in the form of pruritus, other severity. There are so much of list of molecules are there to try for pruritus. Among that, there are so many other new molecules being there in the trial to look for the management of pruritus. How are you going to look for this clinical scenario for this to progress is mainly by once an immune response injury is going to get set in, there might be evidence of your damage of your intrahepatic biliary radicals, that's the small and medium sized radicals. If it is going to get involved, once a patient is going for that, there might be evidence of your chronic cholestatic pathology. It is going to get supervened and the patient can land up with further worsening of inflammation. So there might be evidence for your toxic bile acids. Once a bile acid, if it is going to get too much, if it is going to get accumulate, your bile salt pump, if it is not going to get functioning properly, there might be evidence of toxic dose of your exposure to bile acid, to bile duct. The patient, just a minute, please. So I think you can able to follow me now, sir. There might be evidence of worsening of events in the background. Hello, my voice is audible?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So
Very much, sir.
yes, once the inflammatory cascade is going to take on, the patient can go for fibrotic changes and the patient can finally land up with cirrhosis as the day progresses. So our intention is to stop the process of this progression. How are you going to stop? How are you going to establish the reasonable support? How are you going to maintain the nutrition status of the patient? How are you going to improve the clinical scenario? That's what is most important to discuss with this obeticholic acid right now, what you're going to try for the management of PBC and also in the management of non-alcoholic fatty liver disease. So based the clinical presentation, very simple, right from a basic knowledge to a complex discussion. So the commonest presentation, any autoimmune pathology, once a patient is landing up with cholestatic background, fatigability is high common symptom. The patient most of the time will be fatigable, lethargic, drowsy, not responding much. There might be evidence of coexisting hepatic encephalopathy. So that scenario we are not supposed to miss. Once a patient is going to land up with hepatic failure, but you should remember the common presentation, early fatigability is the most common one. And next to that, the pruritus severity will be very common. Nocturnal pruritus, you couldn't be able to sleep, your restrained activities will be there. All those things has to be analyzed properly. And other common symptoms like jaundice, as we have discussed, then once a patient is going to form this kind of cholestasis, xanthomas, xanthelismas, so many other complications that drop from the basic knowledge about your xerostomia, xerophthalmia, because of your vitamin A, D, K, ADE and K support, if it is going to come down because of your cholestatic injury. That's why once a patient is going to land up with cholestatic liver disease, you need to subject, you need to give the patient with vitamin A, D, E, and K. This is how we need to treat the patient. And coexisting other autoimmune, new list of autoimmune pathology like your rheumatoid, Sjogren's, celiac, and thyroid conditions, autoimmune thyroiditis, or multiple other rheumatological focus, so many other conditions you can have a coexisting comorbidity along with this kind of primary biliary cirrhosis if you want to tackle that. And how are you going to diagnose? Always, I would like to point out in my multiple presentation, the most important clinical parameters, you need to look for that. Look for evidence of jaundice, panels, severity, pruritus, scratch marks, xanthomas, xanthelismas, and see whether the patient is having evidence of organomegaly like hepatomegaly or splenomegaly. The pruritus itself, the each marks is very classical if you're going to look into that. And by imaging wise, you can do the baseline ultrasound. Up to that, you can go for MRCP, and followed by, once the patient is going for MRCP, mainly we need to look for evidence of mechanical obstruction. It could be because of choledocholithiasis, it could be because of any tumors, any mass, any ampullary malignancy. There are so many focus for you to predispose to obstructive jaundice. That pathology has to be strongly eliminated if you want to look for the possibility. And MRCP, you can able to see the beaded track appearance by your MRCP accurate imaging you need to do. And next to that, your various markers like your anti-mitochondrial antibody, your AME factors, it should be elevated, it should be positive, and alkaline phosphatase, the one pointer for your cholestatic, along with your GGT can be considered, and AMA negative, even if the background of elevated ALP, there is a possibility, and AST, ALT, ALP, even the background of AMA negativity can be considered, and other autoimmune markers like anti-smooth muscle, anti-liver kidney, all those things can be tried, all those things to be looked into that, even if you want to rule out this autoimmune pathology, because taking one pointer cannot be in the differential diagnosis. Always when you're ruling out all possible coexisting pathology, you can narrow down your diagnosis to this primary biliary cholangitis. So liver biopsy only when you're going to suspect a woman with a possibility of PBC, a persisting elevation of ALP, but AMA, if it tends to be negative most of the time, then you can consider the patient for liver biopsy to prove that it's mainly because of your primary biliary cirrhosis. So the main area for us to take on the discussion is how are you going to manage the patient. First, we need to halt the injury, we need to prevent the injury from, and we need to halt the bile duct inflammation to progress, and we need to slow the rate of progression of disease, and we need to alleviate the coexisting symptoms, and how are you going to improve your liver biochemical parameters. These are the things and long-term consequences because of vitamin A, D, E, and K, as we all know that right from a basic knowledge. So all the basic complications of this vitamin A, D, E, and K has to be prevented consecutively if you want to manage this kind of patients. So huge list of drugs. Only if you want to think about the pruritus, now even rituximab can be considered, and so much of a list of drugs. That's a separate area for me to take on the discussion. Since the time is not permitting, I am restricting myself only to the prescribed area of focus. So UDCA, obeticholic acid fibrates, new biological agents that what I've been discussed, budesonide can be tried, but other drugs like your corticosteroid, cephalosporin, there is high possibility of further worsening of events, and methotrexate can be considered, but when you're going to use obeticholic acid, always you should be cautious and you're going to give cyclosporin, because there is high possibility for this cyclosporin can have worsening of events in your bile salt export pump, which tends to accumulation of your bile salt. So the obeticholic acid response will definitely will going to get ample. So don't use obeticholic acid much along with cyclosporin. It's not much of guidance to recommend an antihistamine safely for pruritus, and UDCA, obeticholic acid, as of now, those two are strongly approved molecules in the management of PBC as by FDA, which has been proven, documentation has been, guidelines have been recommended from 2016 onwards. The papers are being there to report, and even for non-alcoholic NASH, non-alcoholic steatohepatitis, there might be multiple papers to support the evidence of obeticholic acid, but still FDA is not significantly approving this molecule in the management of non-alcoholic steatohepatitis. So once the patient, if you're going to diagnose as PBC, as what I've been discussed based upon your clinical picture, your liver biopsy, your autoimmune markers, and your cholestatic background, so you're going to narrow down your diagnosis of PBC. So first line of molecule, as we all know, right from your basic knowledge, we need to start with UDCA at the rate of 13 to 15 milligrams per kg per day. And we need to serially, we can go even up to 20 to 30 milligrams per kg, and sometimes even 600 milligrams twice daily, up to 1,200 milligrams. Also, some papers are being there to support the evidence, but monotherapy of UDCA at high doses, even if it tends to be anti-pruritic, anti-cholestatic, and anti-inflammatory, anti-apoptotic, so many pathways of action of this UDCA, no much of recommendations if you're going to lay, going beyond the recommended doses. Next to that, you need to see whether the patient is responding to UDCA or not. How are you going to assess? You need to see the histological parameters, you need to see the ALP, you need to see your bilirubin levels. If your ALP, if it is going to come down, your bilirubin, if it is going to come less than 1 times of your upper limit of normal, then better to continue UDCA. Usually 8 to 12 months of therapy can be tried with this UDCA, but there is no response in the management of PBC. Always you try to consider with adding a second line of drug. That's nothing but none other than OCA, obeticholic acid. But we can titrate the dose start from 5 milligrams and we can go up to 10 milligrams. So many papers, even 25 milligrams being tried, that I'll be discussing with you all in upcoming slides. I'll look for the response of this obeticholic acid, see whether ALP, if it is coming down to less than 1.6 as I discussed, and bilirubin if it is getting normalized, and greater than 15% of decrease in your ALP, then might be evidence. Then you can continue this obeticholic acid safely. If it is not responding, then you need to go for other molecules like bisafibrate, fenofibrate, or you can refer the patient for other trials. So baseline UDCA is the most important thing you can check on with the discussion. Divided doses, two divided doses, proven indication, and most of the 40% have a suboptimal response. So there might be evidence that the patient can go for worsening of even that what I've been discussed, like fibrotic and cirrhotic changes can happen. So higher doses not show much of effective, but not to be used many of the kinds. So don't go for very high dose of UDCA when you're going to manage a patient with this primary biliary cholangitis. So addition of a second agent is definitely most important to bring down your bilirubin status and also to improve your ALP levels, despite when you're going to use a UDCA therapy. Now, the main armamentarium for me to take on with this obeticholic acid, it's nothing but your steroidal derivative. It's mainly by echinodeoxycholic acid derivative. What is this? It's, if you're going to look into the, it's a semi-synthetic derivative of your endogenous primary biliary acid. So it's nothing but CDCA. So if you're going to look into this basic thing, it is by anticholestatic and anti-hepatotoxic effect if it is going to get happen. And you can try this even for your non-alcoholic steatohepatitis. How does it going to have implicate its mechanism of action is mainly by targeting your nuclear receptors. Nuclear receptors is going to maintain your homology with your various strains. Once the patient's nuclear receptor is going to get involved, it modifies the synthesis of your bile acid, and this that's how it's going to target your FXR pathway. What is this FXR pathway? If you're going to look into this, it's nothing but Farnesold X receptor agonist. What is this FXR? It is going to locate in your human enterocytes, your hepatocytes, which is going to act as the naturally occurring bile acids, most often the ligands for your Farnesold X receptors being considered. So if you're going to take your enterocytes, this FXR regulates your bile acid synthesis. And how does it going to regulate? By releasing your FGF19. What is this FGF19? It's nothing but fibroblast growth factor 19 into your hepatoportal circulation. Once if it is going to get released, the effects are, the main role is regulates your hepatic TGL synthesis, and it halts your fibrotic pathway, and multiple other metabolites is going to get involved in this pathway by your various domains, which is going to get involved. Once this effects are, once the fibroblast growth factor 19 is going to get activated, and if it is going to get released into portal circulation, this slides are not there, but only by a theoretical concept I'm discussing with you all. So what is going to happen? This FGF19, if it is going to get released into your portal circulation, it binds to FGFR receptors. FGFR receptors is nothing but your type 4 receptor. So once if it is going to get released, it's going to suppress your CYP7A1 pathway. What is the CYP7A1? It is going to regulate your cholesterol synthesis. So see, you're going to see your bile acid pathway. How is it going to come down? Mainly by your cholesterol conversion to your bile acid. So once it's going to suppress your CYP7A1, the enzymes which is going to responsible for converting your cholesterol to your bile acids. So this inhibits the bile acid synthesis in your hepatocytes. Once the bile acid synthesis, if it is going to come down, the toxic accumulation of bile acid is not going to get happen. That is why the mechanism of action of FXR agonist of obeticholic acid is there to take on the discussion with you all right now. So it is going to also, so if you're going to look into that, it's going to also activate your circulating bile acid pool. So if you're going to see this slide, so there might be direct effect on your bile acid efflux and also by your indirect effect on decrease in bile acid synthesis and uptake. So there are various genetic factors being involved in this expression. And once the bile acids affects a pathway, which is going to involve in huge areas like hepatocytes, small bowel enterocytes, your beta cells, your adrenal cells. So the main effect by your efflux of your bile acid and decrease synthesis of your bile acid, thereby preventing more amount of bile acid formation, and thereby that's not going to produce a detrimental effect in your hepatocytes. Once the bile acid accumulation is going to come down, the detrimental changes will not going to get happen. Thereby, the patient clinical status is going to get respond very well in the management of primary biliary cholangitis. This is what I've been discussed. So once if it is going to get formed that there might be evidence of conversion to your various parameters, it's going to get metabolized. The metabolism of this obeticholic acid is going to happen in your liver, and it gets conjugated by glycine and taurine. There are so many pathways there that I'll be discussing in a few slides, upcoming slide. And next to that, once the conjugation happens, it's going to get deconjugated in a small bowel by your enteric bacteria, the organisms, what are the things is going to get located. And this deconjugation process by that followed by there might be evidence of enterohepatic circulation, which is going to get activated, followed by the patient, the intestinal microbiomes will be involving in this process of conversion. So why I would like to point out that it can also regulate your cholesterol synthesis. See, if you're going to see this picture, the insulin sensitivity is going to very well improve once you're going to use this obeticholic acid. How? It's going to decrease your gluconeogenesis, it's going to decrease your glucose output, and it's going to improve your glucose uptake, and it's going to improve your glycogenosis. So once the glycogenesis, another pathway, if it is going to get improved, there might be evidence of your insulin synthesis and secretion is going to get well improved, along with your glucose uptake and energy expenditure is also reasonably improved. So activates your suppressed hepatic gluconeogenic expression and increases your hepatic glycogen synthesis and glycogen content by a mechanism involving enhanced insulin sensitivity. So it is going to help in improving your insulin sensitivity and promoting a gluconeogen, reducing a gluconeogenesis and promoting a glycogenic pathway. Thereby, it's going to improve your cholesterol metabolism. Thereby, it's going to prevent the formation of non-alcoholic steatohepatitis. Worsening of events tends to get happen. So it's going to produce a significant efflux, and it's going to reduce your bile acid synthesis, thereby acting as a effects of agonist. That's one most important thing I would like to consider. And it is going to regulate your glucose output by your insulin sensitivity mechanism. That's how the mechanism of action of this obeticholic acid as FXR agonist, that what I've been discussed. It's a nuclear receptor expressed in the liver and small, intestine, and it's going to regulate your five bile acids by anti-inflammatory, fibrotic, and metabolic pathways. So de novo synthesis of your cholesterol is going to come down, and by increased transport of bile acids out of there. But you need to remember these two major points: your cholesterol synthesis suppressing and transport of bile acids. The efflux of bile acids is going to get augment. That's how these mechanisms limit the overall size of your circulating bile acid pool while promoting your cholestasis and thereby reducing the hepatic exposure to your bile acids. So our target, we need to bring down the level of bile acids significantly to prevent, to cause various detrimental events to set in. And pharmacokinetics, nothing much to discuss, more of theoretical purpose. Remember one simple thing: it is going to metabolize by formation of your glycine and taurine, and it's going to get conjugated and deconjugated by your intestinal microbiomes. And next to that, the elimination source is mainly through your fecal route and less than 3% by your urinary pathway. And main indication, as I discussed, the approved indication is PBC, in which we are not going to experience much of the scenarios right now, but there are so many papers to look for that. And next to that, non-alcoholic steatohepatitis can be considered. But the only thing, considering this as monotherapy, it's not much of guidelines to prove that, but as a second line therapy, as an add-on molecule to UDCA, definitely we can consider obeticholic acid in the management of your primary biliary cholangitis. So if you're going to look into this dosages, basic things, always start by 5 milligrams, and some guidelines are given even up to 10 milligrams if the patient non-cirrhotic, only in the background of steatohepatitis. But once a patient is going for cirrhosis, the patient has to come in the domain of gastroenterologist. The patient, we need to analyze whether the patient is going to be A, B, and C. Once the patient is going for Child-Pugh A status, which means based upon your bilirubin, your ascetic status, your encaphalopathy patient, your prothrombin time, INR, all those parameters, your albumin status, all those pointers to be taken into account, followed by once the patient is going for Child-Pugh A or B or C, we need to decide the dose. So what's the latest guidelines I've mentioned? If the patient is childpox A, so what we can try, some guidelines are mentioned thrice or twice weekly, we can give the dose, but B and C, weekly once regimen, most of the papers are being recommended, but we should not go beyond 10 milligrams once the patient is going for this kind of worsening events, but maximum titrated doses, some papers being tried even up to 25 milligrams, but some papers being tried even up to 50 milligrams. And once the patient is going for severe decompensation, not more than twice in a week to be tried if you want to try this obeticholic acid. Always you should remember that there are so much of adverse events also when you're going to use obeticholic acid. That's why the domain is to be strongly in the consideration of gastroenterology when you're going to prescribe a high volume drug to a patient with non-alcoholic steroids. Just like that, do not use this molecule. I'm seeing many patients outside where many physicians who have been seeing just a fatty liver damage, just like that they are being initiating with obeticholic. That's not the scenario. You need to look for the prominent indications. You need to consult with the gastroenterologist, followed by you can initiate the molecule. How are you going to use? How are you going to titrate? So routine monitoring during treatment for obeticholic acid for disease progression and the occurrence of liver related adverse reactions, always you need to see when you're going to subject the patient with obeticholic acid. The adverse events is the huge list. Is the commonest adverse event will be a pruritic one, but fatigability, abdominal pain, your oropharyngeal dysesthesia. Along with that, the patient can have worsening of nausea, vomiting, diarrhea, and sometimes even the patient can have your pruritus tends to be get worsening. And next to that, there is high possibility once the patient is going for child A, B, and C cirrhosis or decompensation, there is high possibility for you to have worsening of ascites. There is high possibility for you to have worsening of your portal hypertension. There is high possibility for you to develop your more severe varices in which you may deserve a banding or other therapies for by a gastroenterologist. So why I would like to point out, always you need to be cautious. You need to see overall the patient deserves this kind of therapy based upon the various drugs what they've been recommending. And this pruritus intolerable with even with obeticholic acid, we can try antihistamines or bile acid binding resins can be tried, but bile acid binding resins is one problem with that. It is going to act counteract with the obeticholic acid, and there might be tampering of your effects of obeticholic acid can happen. That's why most of the time we will not recommend the bile acid resins along with your obeticholic acid. But once a patient that what I've been discussing with you on the cirrhosis and non-cirrhotic background, you need to titrate the patient, the dosage guidelines, the decompensation, don't go more than twice in a week. That's most of the recent papers been proven that. But consider discontinuing this OCA treatment in patients who continue to experience persistent intolerable pruritus despite the maximum level of medical strategies which is going to available. Pruritus, we can try with UDCA, rifampin, antihistamines, cholestyramine, so many drugs, now elafibranor, but so many new molecules, right? Rituximab, your albumin dialysis, so many pathways, your nasobiliary, drainage procedures, so many pathways are there, so many methodologies that to improve the pruritus. That's a separate area for discussion. But why I would like to state that you should be cautious about the adverse event. Even cholestatic PBC itself will predispose to pruritus. Obeticholic acid, the molecule which is going to respond to PBC itself can worsen your pruritus. So always you should be cautious, assess, do monitoring, frequent titration. Based upon that, you can go with this obeticholic acid safely. And warning and precautions, as I discussed, once the patient is going for childpox B, C, cirrhotic background, you should be very cautious not to be used much. And liver-related adverse event that what I've been discussed, worsening of your portal hypertension, ascites can happen, and severe pruritus, always better avoid, consider the patient early for transplant, and reduction in your HDL cholesterol. But why you are documenting this? When you're going to subject the patient with this, there is possibility for your LDL to go high, there is possibility for HDL to go worsen, and there might be possibility for the drug to interact with your warfarin. There might be possibility for the drug to interact with your cyclosporine and other molecules when you're being tried for this autoimmune liver pathology. So be cautious when you're going to look into that. This is one of the drug interactions, and these are all the various drugs which is going to get interact with this obeticholic acid. As we have discussed, the bile acid binding resins, if you're going to look, always you need to take 4 hours prior or 4 hours later after ingestion of your obeticholic acid. And warfarin, always you need to target your INR, not to go more than 1.5 to 2.5. INR means 2 to 3, that's the maximum cutoff. And monitor the dosage of INR as per that. And Whenever you're going to use the COP1A1 substrate, which is also going to have a narrow therapeutic indices. So when you're going to subject this theophylline tizanidine, there might be having increased exposure to COP1A1, 1A2 substrates if you're going to use obeticholic acid. So better avoid these molecules to combine together. And as I discussed, cyclosporine is going to inhibit your bile salt efflux, and the main mechanism of action of obeticholic acid in order to promote your bile salt efflux. So the promoters and inhibitors not to be given simultaneously. So better avoid cyclosporine when you're going to use. And various trials are there to look for the evidence of this. One is mainly in background of PBC. Is POISE trial. What they're mentioning that at the end point, if you're going to combine the patient who have inadequate response to UDCA, when you're going to combine, when you're going to subject the patient to obeticholic acid for a period of 12 months of therapy, that might be having significant evidence that the ALP, bilirubin, and ALP decrease if it is going to be more than 15% of the baseline levels. So POISE trial can be strongly recommended. Multiple papers are there to prove the evidence. And next to that, this is how when you're going to subject with 5 to 10 milligrams of obeticholic acid, that might be showing some significant response with your ALP. That might be showing some significant response with your ALP reduction more than 15 percentage, and your bilirubin output to come down in the management of around 10 milligrams of your obeticholic acid. But baseline, start always safe side to be with 5 milligrams. If at all, if you want, you can step up to 10, but going to 25, definitely to be considered. You need to think more when you're going to subject the patient to such high doses. And monotherapy can be tried in the management of primary biliary cholangitis. And what have been mentioned, the response at 3 months can be considered 38% of the patients going to have a significant response, and the mean reduction of ALP was almost around 246 for obeticholic acid 10 milligram. So monotherapy by pooled analysis versus what being as per Wakaliwa concepts, we can consider that, but you need to be cautious when you're going to use as a monotherapy. The most important indication is always go for a dual therapy with the UDC and obeticholic rather than considering as a monotherapy. But in POISE trials, what I mentioned, the 5 to 10 milligrams group and the 10 milligrams group are being having a significant decrease in the placebo when compared to your placebo in your alkaline phosphatase as your total bilirubin. And pruritus, not much of support for this pruritus if you're going to consider. And along with that, obeticholic acid administered with UDCA or as monotherapy for 12 months in patients with primary biliary cholangitis. That's what I've been discussed. It shows going to be a significant decline of your ALP and your bilirubin levels when compared to a monotherapy of UDCA alone. So long-term effects, what they mentioned, see, we need to look for the serial pointers, we need to look for your inflammatory markers, and all those. There are various scoring systems like Globe and UK PBC scoring system, so many Paris criteria, so many criteria are there to diagnose this PBC, but that's not the area for me to take on the discussion. But remember that, look for the enzymatic parameters, look for your fibrotic changes, and look for the bilirubin level, whether it's going to get improved as per POISE trade, which is going to be recommended. And this is how the serial changes we can able to analyze. Your ALP concentration is going to come down significantly. Important thing for us to take on with that. And various guidelines from your European guidelines to ASLD, from ACG, what they're going to mention, that is shows significant response when you're going to use this for your primary biliary cholangitis who cannot tolerate UDCA alone. So Briefly about the molecular response in your non-alcoholic state of hepatitis. As we all know, in Indian population, if you're going to be alcoholic, 80 to 90 to 100% of the population will be having fatty liver. Once the patient is going to continue that, the patient has evidence of fatty liver to get worsening alcoholic steatohepatitis. But even now, the Western scenario is going more common because of your metabolic syndrome, uncontrolled diabetes, obesity, irrational things. And once the patient weight ratio, if it is going to go high, the metabolic parameters, if it is dyslipidemia, if it is going to get set in, the non-alcoholic steatohepatitis is very common complication nowadays being reported for us to manage this scenario. So obeticholic acid NASH has been significantly guidelines of that because it is going to bring down your, improves your insulin sensitivity. It regulates your cholesterol synthesis. So what they mentioned in that, so in preclinical studies, it's going to improve your steatosis, your fibrosis, and your portal hypertension, and type 2 diabetic patient. What they mentioned that is that shows evidence of your improvement of your insulin sensitivity and reduce your baseline liver enzyme level. So the less lipophilic bile acid UDCA binds negligibly to FXR, and a randomized trial, it did not show significant effect in your NASH. So that's why you need to consider this obeticholic acid even in the armamentarium to manage a patient with non-alcoholic steatohepatitis. So there is a multiple FXR mediated activity response is going to be there when you're going to use this obeticholic acid. It's nothing but Farnesold X receptor agonist. So it's going to improve your insulin sensitivity, it's going to modulate your lipids, and lowers your free fatty acid synthesis in your muscles and liver, thereby your hepatocyte protection against your bile acid induced cytotoxicity. As I discussed, anti-inflammatory, anti-apoptotic, and activation of your hepatic stellate cells is going to be there, and it's reduce activation of stellate cells, and it's going to prevent the formation of fibrosis. So your hepatocyte injury is going to get involved, it's going to get prevented, and stellate cell activation is going to get inhibited, followed by anti-inflammatory effects is going to get supervened, insulin sensitivity is going to be well augmented. That's why the Farnesold X receptor agonist like obeticholic acid is going to take on the discussion with your non-alcoholic steatohepatitis. If you're going to see once the insulin resistance is going to get happen, what is going to happen? There might be evidence of free fatty acid to get accumulate, lipogenesis is going to get worsen, all the pathway dysfunction, your mitochondria going to get dysfunctional mitochondria followed by apoptosis. It's nothing but programmed cell that is going to take on, and this hepatocyte cell-led cell activation will be predisposing to multiple inflammatory markers is going to get released. That's how the collagen deposition is going to get happen, thereby the fibrotic changes is going to ensure. That's why we need to prevent, we need to target, we need to control this in this area, the Farnesold X receptors agonist. It's going to take on this if it is going to be there, if it is going to be high level, it prevents the toxic formation of your bile acids, thereby preventing this mechanism to take on. So once a steroid response element augmenting activity, if it is going to be very high, the free fatty acid accumulation will going to be there. So if it is going to inhibit in this pathway, the FFA activity, if it is going to come down, the lipogenesis is going to come down, your apoptosis is going to be well prevented. So that's why the mechanism of action of obeticholic acid is going to take on improving insulin sensitivity, increases your weight loss, reduces your liver enzymes, reduce your inflammation fibrosis. You can do your fibroscan testing nowadays, very well available in high volume centers. And when you can do your fibrotic test, we can see whether the patient is progressing less in F1, F2, F3 stages. Separate area for discussion. And there are newer trials like Flint trials, Regenerate trials. So many trials are there to document this evidence of support in non-alcoholic steatohepatitis. But still, FDA yet to conclude that. And the only adverse events, what they've been recommending when you're going to use, there might be evidence of pruritus in the background of NASH patients. So you can have a significant improvement in your histological parameters. The fibrosis you're going to see once you subject the patient with obeticholic acid, the fibrotic changes is definitely going to come down. And even in Regenerate trial is nothing but a phase 3 trials for evaluating the efficacy of obeticholic acid in the management of NASH. So what they've been done in that, they have been subjecting the patient with 10 milligrams or 25 milligrams of obeticholic acid. As I discussed, the fibrotic assessment they're doing by F1, F2, F3 staging, and they look for the evidence of fibrosis is going to come down or not, which has proven that that might be having significant benefit. The fibrotic changes from F3 to F2, F2 to F1, it is going to get come down. So reasonable improvement with that. That's why, so your fibrosis improvement was evaluated as per NASH trials, no worsening of NASH, defined by no worsening of hepatitis ballooning or inflammation or your steatosis. So that shows significant improvement. That shows significant improvement in fibrosis when you're going to use for NASH therapy. This is what the baseline assessment. So when you're going to subject with obeticholic acid, the proportion of patients with resolution of NASH and no worsening of fibrosis, that's what the main area for us. So once a patient is going for around 10 milligrams to 25 milligrams, no much of difference, but no major worsening of fibrotic changes. So before concluding, what I would like to point out, do a reasonable clinical assessment, look for evidence of cholestatic background, see who is the targeted patients you are going to manage, and followed by who are all of the molecules you are going to get subject, or really monitor the patient based upon histological parameters, based on your liver function, all those things to be taken care promptly. And once if you're going to do, once see whether the patient is progressing or non-progressing, whether the patient is from compensated to decompensated cirrhosis, whether it's going to get happen or not. And based upon all these pointers, you need to manage a patient with non-alcoholic steatohepatitis or in the background of primary biliary cholangitis. So target the FXR is the most important thing for this obeticholic acid. Promotes a efflux of your bile salt, bile salt export pump, and it reduces the absorption of your bile acids. And third thing, de novo cholesterol synthesis definitely is going to come down. Thereby, the lipogenesis pathway is going to get less activation, and followed by there is evidence of improvement of NASH. But FDA still needs more approval for this data. But monotherapy OCA can be considered in the management of PBC, which could not tolerate UDCA patients. That's what, before winding up this session, I would like to point out with you all. If there is any area for you to discuss, you can have a discussion at any point of time. And thanking you all for patient listening. With this, I would like to wind up my presentation. Any questions, sir?
Yes, sir. Thank you for sharing your valuable views on the molecule and the therapy. You have just nicely explained the detail about obeticholic acid and its role in hepatobiliary disease management.
Sure.
Sir, your views on this molecule regarding particular condition like fatty liver and NASH will be very much helpful, because as you know, this fatty liver condition is very common, and almost 70% of the even diabetic patients are suffering from this fatty liver condition. So any of your in-clinic experience with this molecule in fatty liver disease?
So if you are going to tackle a patient with isolated fatty liver, when you're going to manage a patient with obeticholic acid, we can try, but evidence. When you're talking about evidence in the management of this, it's still we need more documentation. But definitely that shows clinical response. Even my practice and experience, once a patient is going for NASH, NASH is one very tough scenario, because sometimes the patient may deserve admission. Sometimes the patient may have worsening of events, because based upon your histological parameters, based upon your liver enzyme, that shows the evidence of two-fold to threefold elevation of your AST, ALT enzyme, along with the alkaline phosphatase and bilirubin status, if it is going to be high. If you're strongly suspecting NASH always, you should remember that it's a diagnosis of exclusion. You need to exclude all common conditions. You need to see whether the patient is alcoholic. You need to see the patient having virology focus. You need to see whether the patient is having infective focus. So many things are there to look for that. And followed by, once you're going to exclude all those pointers, you can able to diagnose this NASH. So how far you're going to have a significant impact for this kind of patient. So choosing the patient is most important. That's why the obeticholic acid, we can be able to assess a response. But just like that, prescribing for isolated fatty liver, we need to be very cautious because of the adverse events. Some papers have been reported, but our experience, if the patient is going for grade 3 and 4 fatty liver, you can try to some extent, but if the enzymes are normal, always better to have a caution not to subject much with this kind of obeticholic acid, rather than diet, lifestyle modification, along with other molecules that are there for you to have in the armamentarium of management of fatty liver. So always isolated fatty liver, you need to be cautious when you're going to manage with obeticholic acid.
Yes, sir. I mean, as per the trials, there are many, significant results with the obeticholic acid, like in diabetic and NAFLD patient, it improves also insulin sensitivity, it improves
Yes.
NAFLD activity score by at least 2 points. And if we talk about NASH, it significantly improved fibrosis, which is considered to be one of the main tipping point in the disease progression and mortality rate of the disease. And sir, as you're talking about this side effect profile, like in the trials, majority majorly they have conducted this trial with 10 mg and 25 mg, and that too also in the international level. So is there any clinical, Indian experience with these pruritus? Because
Our experience, I have giving some patients with multiple patients with obeticholic acid, but our experience of pruritus is not much of worsening. Don't worry about that.
right, right.
That shows evidence of reasonable improvement. But we need, when we are being in a forum, when you are discussing something, you need to assess two areas. One is by your clinical experience, and one is by the various papers what you are going to get quote of. So based upon the paper, that shows evidence of worsening of pruritus, but clinically not much of significant worsening when you are saying. But always we are not giving as a monotherapy. We are always giving as combination therapy with obeticholic acid. But obeticholic acid is having a significant improvement, definitely for NASH, no doubt about that. But it has to be NASH. Identifying NASH is one of the complex scenario, even for the top gastroenterologist to tackle. That's why choosing the patient is most important. I want to discuss with you.
Yes, sir. One more question, if you don't mind. Any of your observation regarding these liver bioenzymes, SGOT, SGPT, with this obeticholic acid?
If it is getting normalized.
Yeah.
Only with your only see what is the condition. That's what I'm telling you again, sir. So only with this obeticholic acid, we are not having significant data to prove that it's responding, because always we are being combining the molecules. See, if you are going to treat with the PBC, okay, definitely a significant response as a monotherapy also. We are having some trials with that. But in NASH alone, if you're going to use obeticholic acid alone, means we need to have still more data to prove the efficacy. So, yes.
Yeah. Thank you, sir. Thank you. Any other question from the participants?
Yeah, myself, Dr. Bhaskar.
Sure, sir.
Yeah, just good afternoon, sir. Beautiful talk. You could give us real good insights about this molecule. My question is about how long should the treatment be continued after a significant period when the levels of enzymes, all that, in fact, if at all, if it comes down, how long should it be continued?
So ideally, what they've been telling, if you're going to manage a patient with primary biliary cholangitis, we can go up to years, sir. No much of documentation for that. You can go for 1 year, 2 years, 3 years, 4 years. Various papers are there to look for that. But for non-alcoholic steatohepatitis, for 3 months of therapy, it has to show some sort of significant response in the management protocol. So AST, AST level, enzymes, all those things are by 3 months we can able to have a significant response only when you're going to prove NASH. But based upon that, we can serially titrate and we can serially increase or decrease your dose. In the background, not to be a cirrhotic background and not to be and with minimal compensation. No much of worsening of compensation. Yes, sir.
Thank you.
Any other questions for us to take on, sir?
I think, sir, there is no more questions now.
Just the last one. Sorry.
Yeah. Please.
Is there anything to be worried about when using obeticholic acid as with the other lipid agents? So though he told us about warfarin and cyclosporine, only thing about drug interactions, is there anything significant that we have to keep in mind about when we are dealing with the anti-hyperglycemic agents? Okay.
Definitely, we can consider atorvastatin in the armamentarium of management of along with obeticholic acid. No worry about that. So anti-lipid lowering agents safely can be considered along with that, except for, as I've been discussing with you, that warfarin, cyclosporine, a few molecules which is going to be act on the CYP pathway. Apart from that, your anti-lipid lowering agents like fibrates and statins can definitely safely be considered when you're going to manage a patient with a metabolic syndrome.
And just the last question, but because you said that it also improves the insulin sensitivity, is there that we should bear in mind that, especially for patients who are on oral high anti-hyperglycemics plus on insulin, should we keep in mind that there could be a scenario where it could lead to hypoglycemia when we are using this particular molecule?
Definitely, there might be evidence, but along with obeticholic acid, how far the data are being proven that the patient is going to land up with hypoglycemia, along with this insulin sensitizers, that's what the questionable issue. But hypoglycemia can be considered, but isolated adverse event with obeticholic acid to be considered in the management is definitely lesser.
Okay, thank you so much.
Thank you, sir.
Sir, Arun sir, wonderful sir, excellent presentation.
Thank you, sir.
Thank you very much for being with us today this afternoon. Great delivery by sir. And I
Sure.
take this opportunity on behalf of Torrent sir to thank you very much for sharing your valuable time despite your busy schedule to share this. And I also thank a lot for all the doctors who have taken up their time despite the busy schedule, because I do understand that today being the first day of the week, a lot of patients. Thank you very much for taking a valuable time to be part of this scientific program, sir. Thank you very
Thank you.
much, and wish you all a very great day, sir. Thank you very much, sir.
Thank you. Thank you. Thank you all for patiently listening. Thank you.
Yeah, thank you, sir. Thank you.